Hello, I'm Chloe. I'm a quality improvement coach for Perth Metropolitan Northwest. I've been a registered nurse since 2007 and have worked in multiple roles across tertiary systems and primary care. I'm passionate about using quality improvement methodology to assist practices in tailoring their care to their unique populations, especially looking at ways to target their care to those who require it the most and improve health outcomes for underserved populations. I'll hand over to Connie.
Yeah, so I'm Connie. I'm a quality improvement coach for Perth Metro South East. I've been a registered nurse for the last 13 years, and I've worked as a practice nurse and a nurse manager in general practice, urgent care, and women's health clinic settings. In my role as a QI coach, I work to support practices in a variety of ways, including helping general practice staff identify areas of improvement to implement solutions and create positive change. So I'm going to pass back to Chloe, who's going to get us started today by going through the learning outcomes for today's webinar.
Thank you. Jamie, would you be able to pop that onto the next slide for me, please? Thank you. So we'll just run through some session outcomes for today's webinar. By the end of this session, we expect that participants will be able to understand current hospitalisation rates, identify at-risk patients, apply preventative care strategies, promote vaccination, and implement chronic condition management plans and falls prevention, and utilise quality improvement methodologies. Jamie, could you pop forward to the next slide, please? Thank you. We're going to start this webinar by examining some statistics to demonstrate why we need to focus on the care of the older adult population. For the purpose of this webinar, we'll be using the Australian Institute of Health and Welfare, or the AIHW's, definition of an older adult, which is over 65 years or over 50 years for an Aboriginal or Torres Strait Islander patient. The AIHW gathered data from various sources, including state and territory government agencies, the Australian Bureau of Statistics, or the ABS, and other non-government organisations. They also collect data directly through their own surveys and data collections, such as the National Hospital Morbidity Database. The data submitted is analysed and turned into useful information and reports to support better policy and service delivery decision. We can use this data to target care to our areas of needs. So let's see what we have to say from this data about older adults. Jamie, can I get you to forward to the next slide, please? Thank you. So hospitals are a cornerstone of Australia's healthcare system. They provide essential care to millions of Australians every year. In the 2023 to 24 period, there were 12.6 million hospitalisations across the country. Of these, 59% occurred in public hospitals and 41% were in private hospitals. Additionally, there were 9 million presentations to emergency departments. When patients arrive at emergency departments, as many of you may know, they're triaged using the Australasian triage scale, which categorises urgency into 5 levels. In the most recent breakdown report from the AIHW, presentations for older adults fell into the following categories. 44% were deemed urgent, 29% were semi-urgent, 19% were emergency cases, 5.7% were non-urgent, and 1.3% required resuscitation. These numbers paint a powerful picture of the scale and complexity of hospital care in Australia. Now let's take a closer look at how these statistics reflect the experiences of one of our high priority populations, older adults. Next slide, please. Thank you. The graph on your screens now displays the most recent data from the AIHW, breaking down hospitalisations by age group. You'll notice a striking trend for a large percentage of hospitalisations occurring amongst people aged 65 and older. Although they make up just 17% of our population, they accounted for 44% of all hospitalisations and 52% of total patient days, which is a disproportionate share of hospital care usage. Zooming in even further, you can see that people aged 85 and over represent only 2.1% of the population, yet they made up 6.8% of hospitalisations and 13% of patient days. That is a significant impact from a relatively small group. In this age group, hospitalisation rate was 1,521 per 1,000 people, meaning that on average, each person in that age group was hospitalised more than once in the year. Potentially preventable hospitalisations, or PPHs, are our key measure of how well primary care is working. These are hospital admissions that could potentially be avoided with timely and effective care in the community. Older people, along with Indigenous Australians and those in remote or disadvantaged areas, are more likely to experience PPHs. In the most recent data report from the AIHW, nearly 46% of all PPHs were for people aged 65 and over. Amongst this group, the most common reasons for hospitalisation included chronic obstructive pulmonary disease, or COPD, congestive cardiac failure, or urinary tract infections. This demonstrates that we need to focus on managing these in the primary care setting. Older adult statistics. As of June 2020, over 1 in 6 Australians were aged 65 and over. Most of these were in the 65 to 74 age group, accounting for 56% of older adults. About 31% were aged 75 to 84, and 13% with 85 and over. Life expectancy continues to rise. A man aged 65 could expect to live another 20.2 years, and a woman 22.8 years, bringing their average ages at death to 85.2 and 87.8 respectively. Looking ahead to 2066, the older population is projected to grow substantially. Over 4.5 million people will be aged 65 to 74. Those aged 75 to 84 will make up 1/3 of the older population, and 1 in 5 older Australians will be 85 or older. This shift in age profile signals a clear message. Our health systems must evolve to meet the growing and changing needs of older Australians. Health service use. This slide shows the rate at which older adults access health services, particularly general practitioners or GPs. GPs are usually the first point of contact in our healthcare system. They play a vital role in managing a wide range of health issues and in preventing avoidable hospital visits. In the AIHW's most recent report, an estimated 95% of older Australians, or 3.7 million people aged 65 and over, visited a GP at least once. Over half of these were aged 65 to 74. To put this in perspective, older adults accounted for 30% of all Medicare claims for GP visits, 43 million claims out of a total of 141 million. These numbers highlight just how essential GPs are in supporting the health of older Australians and managing demand across the broader health system. As we've seen, older Australians are accessing health services at high rates, and that demand is only expected to grow. So the question becomes, how can we in primary care step in to make a meaningful difference? Our coming slides begin to answer that, showing how targeted, well-coordinated primary care can support older adults, reduce hospitalisations, and improve overall health outcomes. Let's take a look at your patients. How can we find the patients that really need us? One method is to look at reviewing the practices around opportunistic interactions at the practice, starting with the first line of contact for patients entering the practice, which is receptionists and administration staff. Upon meeting a patient, a receptionist could consider the patient's age, what they're attending for, could they be eligible for any additional services? Do the staff have availability to complete these today? And when is the next appointment for the service available, if not today? And book that patient there. For those patients that aren't coming in, we can look at how we can use your practice data to identify them. One way is to utilise your clinical software. I appreciate that there are lots of different clinical software packages in use, and we're unable to list each one today. The example on your screen is the database search feature in Best Practice, and that one allows you to create and run custom SQL queries, which identify specific patients and display the names of the patients in list format. From here, you can bulk add reminders or create a recall list for phone calls or for letters. If you need assistance with identifying data in your clinical software, this is definitely something our QI team can help you with. Or to help access and use patient data, there are external data extraction software packages available to help you identify and target patients faster. Primary Sense is one such program. It's a population health management, clinical decision support, and data extraction tool designed for general practices. It provides real-time alerts, reports, and patient care prompts to help GPs deliver the right care at the right time. Hopefully your practice is already using this. And if you have it but aren't familiar with how to use it, please do contact us for a demonstration. If you don't have it, you're welcome to contact us as it is provided at no cost via WAFA to general practices. One really useful report for identifying vulnerable older adults is the Frailty Care Management Report. This report focuses on identifying older patients, specifically those aged 65 and over who show signs of frailty. The indicators include things like falls, nutrition issues, lethargy, feelings of depression, either recorded in the past 2 years or marked as active conditions. It also includes patients with a frailty score from the Johns Hopkins ACG tool, flagging conditions such as incontinence, skin ulcers, and dementia. Additional flags include patients living alone, those currently on benzodiazepines, and those with recent chest infections or influenza. You'll also see the date of their last flu vaccination or a note if they declined it. This report does help us pinpoint patients who may be at risk of seasonal respiratory infections, which we can allow targeted health promotion. It is also worth pointing out, as always, that this data is only as good as the data being correctly entered onto the clinical software, highlighting the importance of good clinical coding, good reporting of immunisations, and documenting residential status so that we can target patients outside of those in residential aged care facilities. The report's interactive and filterable. You can sort columns alphabetically, chronologically, or by severity. You'll also notice blank spaces where data hasn't been recorded or the data falls outside the timeframe. There's a search function to help locate specific patients, and you can see if they already have upcoming appointments. If needed, you can remove individual patients from future reports after 12 months. And for convenience, the report can be exported to Excel or CSV file, printed directly, and is automatically saved to your practice's computer. The tool is designed to support proactive care, helping us identify patients who may benefit from a review or follow-up to confirm their frailty status and ensure timely intervention. We'll discuss some other primary sense reports as well throughout the presentation. So if we found some patients using these reports at risk of potentially preventable hospitalisations that may benefit from more targeted proactive care, what can we do? One option is the 75 Plus Health Assessment, which is an annual Medicare initiative designed to improve the health and wellbeing of older Australians aged 75 and over. It aims to identify potential health risks so that they can be managed in the community setting, decreasing the risk of hospitalisation and promote healthy ageing and independence by proactively addressing medical, functional, psychological, and social needs. There are templates for undertaking a 75 Plus Health Assessment, such as the ones provided by practice management software and others available for download online. Shown here is an area from the template in Best Practice. However, it should be noted that these templates are designed to address the minimum assessment criteria that tick the boxes of the MBS. The practice team can add anything they like to this to address the needs of their patient demographic accordingly. There are many additional assessments that could be of benefit to consider incorporating. You also need to ensure the templates you are using are continuing to be updated to reflect any MBS changes. So we'll discuss how to make sure the template being used is MBS compliant. Obviously, the best place to start is MBS Online. Simply search for the relevant MBS billing item, and then, this is key, make sure to expand the extended notes section at the bottom of the item description. For health assessments for patients aged 75 and over, you'll want to open note AN039, which outlines the specific requirements and inclusions for that item. On your screen now, you can see the area to find this link to click, and we will include the direct link in the information sent out after the webinar. Once you click through to AN039, the requirements and considerations for completing the health assessment are displayed. It is important to keep checking this regularly, as this is where any updates will appear. So we'll take a moment now to just look at what the current MBS regulations are for a compliant health assessment. That is current for those watching this live. I'm aware this will be recorded and uploaded to YouTube. So if you're watching at a later date, please do check again. The regulations define this assessment as a review of a patient's physical, psychological and social function, along with consideration of any preventative healthcare or education that could improve their well-being. It must include, as a baseline, personal attendance by a GP or prescribed medical practitioner, measurement of blood pressure, pulse rate and rhythm, a medication review, a continence assessment, review of immunisation status for influenza, tetanus and pneumococcus, evaluation of physical function, including daily activities and any falls in the past 3 months, assessment of psychological function, including cognition and mood, review of social function, such as the availability of support and whether the patient is a carer. There is much more information in note AN039. Please read this in full to ensure your assessments are compliant. So, other than meeting the minimum MBS requirements for a health assessment, in considering how to make our health assessments have the most impact and improve patient outcomes, we might think about additional services that we could provide alongside to assist with this. They could include things such as performing an additional frailty assessment or nutrition assessments, and there are lots of tools available for this. You'd need to investigate which one would be best suited to your patients. You could discuss preventative health measures such as cancer screening and immunisations, including education on immunisations that may be available other than those funded by the NIP. Sometimes patients are quite happy to look into private vaccines once they understand the benefits of them, and they may have other means of funding them, such as private health insurance or DVA cards. It's advisable to give patients the information required to make their own inquiries about these. Another important but often overlooked area is advanced care planning. The over 75 health assessment is an excellent opportunity to introduce patients to the idea of advanced care planning and giving patients some things to think about and discuss with their families. You can get lots of great information on this from WAFA's Greater Choices team, and a link to their page on Practice Assist will be sent out in the follow-up emails. It can also be an ideal opportunity for providing lifestyle education or health education on things such as regular DEXA or bone density scanning, falls prevention, exercise, nutrition, smoking, alcohol, or continence management, and is a great opportunity to address social isolation by supporting patients to find like-minded people through things such as community groups, classes, outings, or clubs. Some practices might have a compendium of suitable local services that they can offer to patients. It is also worth investigating other services that might complement care provided by the practice to the patient. These could include things like the bone bus, community physio, my aged care, continence assessment payments, etc. Patients that had difficulty navigating services may benefit from referral to care finders, who help to connect patients to appropriate care providers. A link to care finders will also be provided in the follow-up emails. This is an example of how we can use another primary sense report to identify patients who may be eligible for an over 75 health assessment. If you select the report named Health Assessments, it will pull data from the clinical software and will deliver this table of your patients that may be eligible for a 75 plus health assessment. The table can be filtered by ACG score, which allows you to target the most at-risk patients. It can be filtered by age, ATSI status, as well as the last assessment date and existing appointments. From here, you can look at inviting those eligible in for their 75 plus health assessment. As always, it is also a good idea to check eligibility via HPOS, as this only takes information from your practice data, and also invite them to register with My Medicare at the practice if they haven't done so already. Have a little look at vaccination for preventable disease. Older adults are more susceptible to disease and chronic conditions and have less capacity to recuperate. This is caused by a combination of factors, including anatomical and physiological changes, their increased risk of hospitalisation or invasive procedures, but mostly age-related changes in the immune system, which is known as immunosenescence. Studies have shown that the presence of one or two chronic health conditions is associated with a 40 to 150-fold increase in the incidence rate of influenza or pneumonia. In Australia, the NIP funds annual influenza vaccination, COVID-19 boosters, and shingles and pneumonia vaccines for older adults, recognising their significant risk of these infections. This age group could also be encouraged to consider a diphtheria, tetanus and pertussis or DTPA booster and the RSV vaccine on a private basis. The 75 plus health assessment is a great opportunity to provide this information and check that patients are up to date, or you can use primary sense or practice management software searches to identify these patients as a proactive quality improvement campaign aimed at this population. I'm now going to hand over to my colleague Connie to discuss some further ideas.
Multidisciplinary team approach. Falls are the leading cause of injury-related hospitalisations in Australia, with people aged 85 and over most affected during 2023 to 2024. This high rate is closely linked to frailty, which is a condition commonly characterised by reduced strength, endurance, and physiological function. Frailty increases vulnerability to adverse health outcomes, including falls, fractures, and hospitalisations. Injuries often occur in frail individuals who have diminished balance, slower reaction times, and impaired mobility. Preventing falls in frail older adults requires comprehensive risk assessments and early identification of frailty in our patients. This can be through increasing the use of the frailty assessment tool, mini nutrition assessments, and the alcohol audit C assessment. We can use multidisciplinary team care interventions, which we'll look into next. We can look at environmental modifications that can be made to reduce trip hazards around the patient's home. Training staff to recognise frailty in the practice setting is key. Simple observations like how easily a patient rises from the chair and walks to the consultation room can reveal early signs. By identifying frailty as a major contributor to fall-related injuries, we can better target prevention and improve outcomes for older Australians. So if we look closely, frailty and fall-related hospitalisations usually stem from multiple contributing factors. They often result from a combination of chronic conditions such as arthritis, diabetes, or cardiovascular disease, medication side effects, poor vision or hearing, environmental hazards, muscle weakness, or balance issues. Addressing these requires collaboration across disciplines. No single care provider can manage all of those risks alone. So multidisciplinary teams bring together various healthcare professionals such as general practitioners, nurses, physiotherapists, social workers, and pharmacists, contributing specialised knowledge, which helps in providing effective care. So here we have an example of a team approach to providing care for the older adult. Within the team, there may be a practice nurse who undertakes quality improvement activities to firstly identify patients that could benefit from a health assessment or chronic condition management. Then, when the patient attends for their appointment, the nurse will perform all of the usual tasks, such as monitoring health status, education, immunisations, and other preventative health, as well as appropriate documentation of the condition and goals for the care plan. The GP will see the patient for potentially any further medical assessment and diagnosis, management of the chronic conditions, and can refer to other healthcare professionals to enhance the patient's care. Just some examples include referral to physiotherapists who can deliver strength and balance training to reduce falls risk, occupational therapists to conduct home safety assessments and recommend modifications, pharmacists who can review medications and make recommendations that may reduce medication side effects such as dizziness. Dietitians can work with the patient to address nutritional deficiencies that may contribute to frailty. And social workers can support the patient to access community services and address social isolation. So now let's take a brief look at quality improvement, or as it's commonly referred to, QI. The Royal Australian College of General Practitioners, or the RACGP, defines continuous quality improvement as an ongoing activity undertaken within a general practice with the primary purpose to monitor, evaluate, or improve the quality of healthcare delivered to practice patients. QI involves regularly reviewing and refining your practice's systems, structures, and clinical care. QI activities are a requirement for practices who want to be accredited against the RACGP standards and to be receiving PIP-QI payments. QI is most powerful when it's embraced as a whole-of-team approach. It drives better patient outcomes, safety, satisfaction, efficiency, and sustainability. Practices engage in it daily, often without realising. The key is to document QI activities so systems and processes can be reviewed, ensuring ongoing improvement in service delivery and patient outcomes. So, how can you capture and document your QI activities? Any work done to improve or maintain areas of your practice in line with patient-centered care can be and should be documented in your quality improvement register, which is this one. For example, have you implemented a new policy? Have you implemented new templates for health assessments and care plans? Have you conducted an audit to identify needs of older adults? Have you acted on patient feedback? Have you introduced workflow enhancements that help identify and engage older adults who may benefit from additional preventative health interventions? Or have you recently completed staff training for cold chain or chronic condition management? All of these are QI activities. Then, activities where you can monitor change and outcomes go into a Plan, Do, Study, Act, which is also known as a PDSA. Firstly, it's important to document your proposed QI activity before commencing. This allows time for thoughtful planning and meaningful reflection throughout the process. Using a PDSA cycle is an ideal framework for this. So what is a PDSA? PDSA stands for Plan, Do, Study, Act, and it's a structured method for testing change, learning from outcomes, and refining strategies for improvement. So to break it down, you make a plan. You're going to define a clear goal, ideally using a SMART goal, develop change ideas, and decide how success will be measured. Then do. You're going to implement the plan and document all the steps taken. Then study. So review your data, compare your outcomes to expectations, and identify what worked and what didn't. Finally, act. So you'll decide to adopt if it was successful, adapt if adjustments were needed, and abandon if the changes weren't effective. The PDSA cycle supports continuous improvement. If you decide it wasn't successful and want to make adjustments, simply duplicate the PDSA, update the start date, and refine your approach. Even unsuccessful cycles provide valuable insights and learning. If you need any support or further information about QI, please do reach out to our team. We'll share our contact details at the end of the webinar. We can work with you to provide support tailored to suit your practice's needs. So let's tie everything together and we'll have a quick look at a journey a practice team could go through to work towards reducing hospitalisation risk in older adults. So our practice has decided they want to work on a QI project with the goal of increasing the number of patients over the age of 75 attending for their annual health assessment. They will use the PDSA to outline all the steps and begin by running the health assessment report in primary sense. The teams decided to work through the list of people eligible, filtering by ACG complexity score, and make phone calls to the patients that are scored as a level 5 or 4. These are deemed as the highest complexity, and so they're generally at the highest risk of hospitalisation due to the complexity of their conditions. So this is where the team meets John when he comes in for his health assessment. We might have all met a John in practice. He's an 80-year-old man who lives at home alone. He's been diagnosed with hypertension, high cholesterol, and arthritis, but he flies under the radar and usually will just come into the clinic when he needs a script or recently for wound care after having a fall. So what can we do for John? Before we even begin the health assessment, I would highly recommend becoming familiar with the older adults health section on Clinician Assist. It's shown here on this slide. There's a number of really useful pathways that can be followed to support and guide the care of older adults. One in particular is the Health and Frailty Assessment Pathway, which includes a range of assessment factors that can and should be integrated into the annual health assessment. If you want any further information about accessing Clinician Assist, you can visit the website as shown there, or just reach out to our team. Back to John. After documenting all of the usual health assessment factors, it's quite obvious that John needs a bit of extra help. So here are just a number of factors identified from the health assessment. He lives alone, he has no family or social support, and he states that he feels anxious and distrusting of the health system. He has difficulty with both getting to the shops and cooking, so will just have a sandwich and a biscuit most days. Most of his time, he'll sit and watch TV, and if the weather's nice, he'll get down to check the letterbox. He scores high on the Alcohol Intake Audit C assessment and can be classified as a heavy drinker. The nurse also observed that he's a little unsteady on his feet as he gets up from the waiting room chair, and he's lost quite a bit of weight since the last time it was recorded at the practice. John denies having any falls at home, and he's adamant that the recent visits for wound care were after he just stumbled and caught his leg on the furniture at home. The nurse asks additional questions here in regards to any knee pain from his arthritis, and John answers that he does have pain and feels unsteady occasionally, but he's rearranged the furniture to use for balance when he's walking around. John informs the nurse that he takes all of the medication prescribed by the doctor, but is also taking some over-the-counter pain medication for his knee. And then he's disclosed a story about some new vitamins he's now taking that the neighbour's given him. The nurse makes an important note on this, as John's already prescribed pain relief medication. So what are some steps that we can take to help keep John at home healthy, safe, and as comfortable for as long as he wishes? So firstly, we're going to check previous billing history to see if he's eligible to be booked in for any additional care services. We can review that his chronic conditions are managed appropriately, and if eligible, book him for another additional appointment on another day for a GP chronic condition management plan. From here, he can be referred to members of the multidisciplinary team, such as the physio, to address his mobility, activity levels, and strength, getting in and out of his chair, or maybe to attend an exercise program like community physio. An OT assessment can look at his mobility aids and to prevent future falls or stumbles. A pharmacist can visit for a home medication review to have a look at what vitamins the neighbour's actually given John and what additional over-the-counter pain medication he's taking to determine if there's any potential medication interactions. The team can also have a look at a referral to Care Finders service. As John has no social support, he may be able to access support from Care Finders to navigate having a My Aged Care assessment done and some necessary home supports be put in place. The team can discuss potential options for help with food shopping or meal delivery that can hopefully provide John with a few more nutrients than the current sandwich and biscuit option. Maybe he'll be interested in attending community activities with other people in his age group as well. His alcohol intake also needs to be addressed, so the team can work with John to reduce his intake safely. The team can also have conversations with John about advanced care planning, explaining the importance of having this completed to ensure that he would get the care that he wanted. So the take home from our story about John is, if the nurse didn't do the health assessment, would we have known that he was living alone, socially isolated? Would we have known that he was taking over-the-counter medication and some vitamins from the neighbour? Would we have had the opportunity to engage John in multidisciplinary care? Would we have been given the opportunity to start discussions for advanced care planning? Finally, just engaging John in frequent appointments to do his health assessment, GP chronic condition management plan, and any further appointments for things like advanced care planning or flu vaccines can help John feel supported by the team at practice, hopefully leading him to be in a safe place where his health and well-being is a priority. So as always, our team of quality improvement coaches are available to assist you in establishing and enhancing QI in your practice. We're happy to provide one-on-one support for your practice around identifying quality improvement activities based on your data. Please do reach out with the contact details on the slide there. So I'm going to pass back to Jamie, who's going to wrap up today's session for us.
Thank you, Connie. I'm just going to take control. Perfect. All right, so we just have a few questions. The first one is, can I do a 75 health assessment and a heart health assessment on the same day, as they are different MBS items?
I'm happy to answer that if that helps. So heart health assessments and ATSI health assessments, although they are different MBS item numbers and billing items, they still count as a health assessment. So they have Medicare set out minimum billing interval times. So no, essentially, there needs to be a 12-month period for health assessments for the over 75s from any other one, although ATSI ones can be done every 9 months.
Cool. Thanks, Chloe. I have another question. How do I get access to Clinician Assist? We do have a link to get access to Clinician Assist, and I will put that in the chat. And if you just click on there, you're able to register, and you'll find more details about how to get access to that. Another question I have is, can I be sent a PDSA example of recalling for 75 health assessments?
I can answer that one. Yes, we can send, if anyone wants one, please just let us know. We've got quite a few templates, and we can also help you create a PDSA if there's something else that you would like to do.
Lovely. Thanks, Connie. And my last question is, if we do a health assessment and identify that somebody needs help in their daily life, where can we go from there?
I can try and take this one. If you're sort of identifying that they're falling between lots of systems, they've got no family help and support or anything like that, then that's where our Care Finders service might be of use. We will also have a link to Care Finders, but essentially that one of their eligibility criteria is somebody who doesn't have that social network able to help them navigate the system through My Aged Care. And there are different providers in different areas, so it would just be about finding the local one to you. But yeah, there'll be some information on them in the handout at the end.
Perfect. Thank you, Chloe. So that brings us to the end of our webinar. I just want to also promote the last webinar of our series, where we're going to be looking at men's and women's health. And I've also put, oh, sorry, we have one more question just came through. Where does Primary Sense pull the frailty flag from in e.g., I'm assuming that's example best practice. So where does Primary Sense pull the frailty from? And an example of that is in best practice.
It looks at lots of different things. So things like the ACG score, which is it's very briefly put, is an indicator of their risk of hospitalisation. It looks at their age, it looks at whether they live alone, any medications they take, particularly benzodiazepines, previous respiratory illness, there's depression. So it's looking at a lot of those clinical diagnoses. And yeah, I'm not quite sure where you're based, but we are very happy to come out and have a chat through things to you as well. It does some very magical calculations behind the scenes.
Cool. Thank you, Chloe. So yes, we have the final webinar on the 19th of November. So if you haven't registered for that already, please do so. And I have popped the registration link in the chat for you there as well. We've also been putting all of our webinars up on YouTube in our quality improvement playlist. So if you have a chance and you haven't been able to attend any of our previous ones, I'll encourage you to jump online and have a look at some of those videos. I think they will be really helpful in your practice. I'd like to thank Chloe and Connie for being here today, and for Cass. I've got to give a shout out to Cass for all of her hard work in the background as well. We do have a QR code on the screen for you as well, and we would encourage you to scan it and fill out the feedback form. It really helps us to find out from you guys what topics you'd like to see in the future, and just overall how you found the webinar today. And you'll also be receiving a copy of the slides, as well as a resource, a copy of the resources that have been used, and some that can help you in practice as well. So keep an eye out on your email for that. Oh, we've got one more question. You guys can answer. What is the men's and women's webinar? Chloe and Connie, you guys can speak to that one.
That is our next webinar that is coming up in November, just looking at men's and women's health. So we will obviously send out an invite for you to register for that with some further information. And yeah, hopefully we will see you there.
Thanks, Connie. And thank you for everyone for attending. We hope that you have a wonderful afternoon.